It's very difficult to get a consensus with another neurologist, so we need some methodology. There are different ways to reach this kind of the consensus. One of them is UCLA methodology. To be simplistic, UCLA methodology is when we have a different statement. We think about the statement. We need information about the statement because we have to do a very big review of the literature, and after that we think in the statement, and after that the members of the board of the consensus have to vote like a Likert scale, and after this votation we have to know if this statement pass or not pass the number, the minimum number necessary to get the consensus.
It's like the best statistical, but also space-wide talking to get all these specialists in NMO and ask them about their opinion and their with a scientific background, what would be their best way of treating a patient according to our Latin American reality. So it's a very important update because now we have medications that are FDA approved, and also they are approved in Europe, so we are starting to get them in Latin America. So we are fighting against the insurances to get them as a good access, a good coverage, but we still have to deal with off-label medications. So with this recommendation and having good data quality, we can go to the local authorities and get approval so our patients can get access and coverage.
Yeah, and other important thing is our region is the biggest region with different realities. We have different access to the treatment and different healthcare systems. So we need to keep in mind that there are a lot of differences among these countries, and I need a consensus in our region. So we need to know that a couple of years ago we don't have any approval medication for NMOSD, and now we have a different medication. All of these medication only for patients with AQP4 positive, and our focus in this consensus is separate patients with and without AQP4 and give a consensus to the neurological community about the treatment.
Also, we broaden the spectrum of patients. We have patients from 12 years old and older, and that was not included before. So now we are considering a bigger population, not only aquaporin 4 positive, as Ricardo said, but also the double negative patients. So that's also a big uptake. Well, I would say it's two main things. First is to fight against the inertia we have all, because we have off-label medications. We know the adverse events, so we're used to them. And these are new monoclonal antibodies that have a different profile, so we need to study and we need to start trying to see how it works and try to get experience with that. So that's one main focus, the physician's inertia, but also the patient's inertia we need to deal, because we really need to educate patients about these new therapies, how important it is for us and for them to get them, to be adherent, and to have a good long-term follow-up as soon as they get the medication. Not to start with off-label ones, but start with good quality medication from the very beginning.
Yes, I agree, and let me add, we have different barrier or challenge. Maybe thinking in clinical barrier, we know that NMO negative patient is difficult to understand the pathophysiology, so we don't know how treat better this patient and the response, and when stop the medication, for example, is maybe a big issue in our clinical practice. Another challenge, let me go back to the access, because our region is a poor region, and we have problem not only with treatment access, also with test access, because in some part of our region, in some country, there are no data about, for example, AQP4 or MOG test, and this is a very big issue for our region.